the body, bacteria, of course, fats and proteins, which are very large molecules. And this will talk about how that pertains to the skin changes that we get. And there's some water. So this all works, lymphatic fluid. Dr. Brown talked about how we can have a minimum of 3 liters cycling of lymphatic fluid through our body. So you can imagine the challenges that we have, in particular with lymphatic fluid, because it's a thicker, denser fluid, because of these high sized proteins, fats, it has a very solid and more thicker texture than what we know as our sort of watery type edema that we know in vascular conditions. And pressure changes that this thick fluid causes against the skin is actually what contributes to these progressive skin changes and inflammation that we see. So we used to, and I always, when I'm teaching fitters, I talk about, let's not think about, you know, if they're lymphatic, they go in this, and if they're vascular, that goes in this, because the reality is we know from the literature, from Dr. Keith, that once they have passed the 3-month mark, you're in a chronic venous, or you're in a chronic edema state. And at that point, you're on some type of lymphedema continuum. And when you think about it, that makes sense, because our lymphatics are about taking out what's not supposed to be there, creating the immune response. And so it only makes sense that they would be there. So after we start with the venous edema, and basically what happens is the blood vessels under the skin that are there to remove fluid, they can't get out, so it's pushed into tissues. When the lymphatic vessels can no longer tolerate the amount of volume there, whether that's from a primary lymphedema, secondary lymphedema, whether it's from a mechanical or some sort of, you know, biological reason, the lymphatic systems no longer tolerate the level of fluid that's in there. So we start with venous edema, and we've seen that. You know, you've got the soft pitting edema. If you can put your finger in it, there's induration. We typically say that there's, you know, that watery type edema. And we know these things from dialysis patients, for example, congestive heart failure, sitting, standing all day, those types of things. Even pregnancy, you know, we've got more blood volume, everyone knows about pregnancy, and the issues that we have there. Again, once we start getting in the 3-month mark, or you're now in a chronic where we have a venous and lymphatic state, you're gonna start to see less of that induration, so the pitting edema. You're gonna start seeing lipodermatosclerosis, microbial eczema, allergic contact eczema, ultimately leg ulcers oftentimes. And again, that very, very thickened skin that's due to that high pressure and the inability for what needs to get there to the skin to heal. And then we get into that chronic edema, venous lymphatic state. So again, when I talk to fitters, I say, let's not try and put them in a box. If they're lymph, they go in this, and if they're venous, they go in this. Because the truth of the matter is that by the time they get to fitters, they are likely in that state. I mean, we're not very good at creating prevention when it's at this stage. And that's really what we need to do better. And Dr. Brown talked about that if we can do that, we'll be in a much better state. So these are some of the skin changes that you're going to see with chronic edema, the hyperpigmentation that we associate with venostasis, or arrhythmia, so inflammation of that skin. Same thing with the stasis dermatitis. You're going to see that scaling type skin. Hemosiderin staining, so our blood has red blood cells, and those red blood cells have iron in different deposits. So as they are leaked into the tissues, they have a life of 72 hours. And so essentially, you can think of it as sort of almost rusting of the skin. And then we get that hemosiderin staining, very popular, not very popular, but very common in that gear area. Atrophy blanche, typically we'll see after a healed lymphangiostis is a very challenging condition, as you can imagine. This skin is not able to get what it needs there, and you can see the hardening of the skin there. We often call this elephantiasis. I can never say, after 20 years, I can still not say that word. And really, it's just an excess amount of keratin and what happens there. So lymphorrhea. I mean, those of us in wound care we've all seen these dripping legs. I was at a clinic, and she said, I thought I had a leak in the roof, but it was onto my bed. But it was actually my legs, and I didn't realize that it was my legs so there wasn't a lot of mobility and able to see. So she thought that something was leaking, but it was actually her legs. And it can pour out. And as you can imagine, we now know what's in that fluid. So it's obviously puts them at a huge risk of infection. When it dries, it's an amber, it can be a little more on the serosane, but it's an amber color liquid that drips out. And when this dries, it creates like a crustation, like a crustiness. And we have to get that off. The skin can't breathe. We can't do wound care, and oftentimes we don't know what's happening under that skin unless, and these guys will talk about how to do that, but until we get that out. But obviously, this is septic fluid, and so a huge increased likelihood of cellulitis when we have lymphorrhea. Now, obviously, this is the most common infection that we see with lymphedema patients, very painful and potentially serious infection of the skin. And I was talking to someone downstairs, and she said that, I was scared. I travel now, but I was scared to travel because there's no rhyme or reason sometimes to cellulitis, but it's a bacterial infection of the skin, often correlates with some lymphorrhea, but it occurs anywhere where there's a breach in the skin, so a cut. Although there's other areas, reasons that they can get bacteria, but basically they get blood poisoning, septicemia. And this is obviously a very potentially dangerous situation. You get high fevers, low blood pressure, and a very, very common reason. Now, what a lot of physicians are not trained in the ORs to know that if you have a cellulitis in a specific area twice, then you really need to look at whether or not we're looking at a lymphedema. However, we tend to just blanket them with antibiotics. And some of these patients can be on antibiotics for years, even chronically. And what the theory is that if you have an already depleted immune function in your cells, what antibiotics do is that they assist your immune system to fight that. It's that extra fighter that comes in. And if you're already depleted in your immune response, one can hypothesize that those antibiotics aren't going to help as much. So we don't know why sometimes there's years in between. Some people can get a bout right after they get rid of the last, and we're actually thinking that perhaps they never really eradicate. It's usually a staph or a Staph aureus or a streptococcus infection, and you never totally get rid of it. And some patients will say, it's like I have this sleeping enemy inside of me. It's just what day is it going to come out? So you can imagine the fear that comes with that, because it can be a potentially dangerous situation. And we see people in and out. And the only way we're going to get that better is if we take out what's causing it and we actually treat the underlying cause, which is the lymphedema. Very, very high occurrence rate, and very, very damaging to the skin. The more it happens, the more you're damaging not only the lymphatic vessels, but the skin as well. And then ultimately, we start looking at the development of lymphatic ulcers. High correlation with venous ulcers. Sometimes we use those terms interchangeably. You're going to get this very firm and fibrotic tissue. Again, why? Because of that fibrosis that's happening, because of the conditions that we talked about. We get to a point where that's not reversible. We try and soften it, but you have the skin folds are notorious for yeast infections, fungal infections. Bugs love moisture, so oftentimes people will not even realize, particularly in these significantly morbidly obese patients, sometimes we will not see an ulcer that is happening, and next thing you know, they're in hospital with septicemia, and we find that there's an ulcer in a fold. Traumatic injuries, obviously, and you know, those of us who deal with compression, we know that there's an issue with compliance. And what do you think the reoccurrence rate is of people that do not continue with their compression stockings? Yeah, I know. It's 98 to 99%. Because what happens is we never get that skin back to its original state. And so it just takes bumping it against a coffee table, any reason. And these guys will talk about the skin, but when you've got swelling, those skin cells are separated, and it's just an open, like an invitation for infection. And so they have chronic infection, and because essentially we have that skin delta because we have the lack of perfusion to the skin as well. So, any questions at all on that portion? No? Okay, so I'm going to pass it off to my wound care colleagues here. Sorry, it's a little crooked, but here we go.
Right. Thank you. Hi, everybody. My name is Rochelle. I'm a clinical wound specialist with SD. Daniel Stubbe here, he's our hydrobaric expert. We're just going to continue the discussion today, mostly focusing on cellulitis and venous leg ulcers that are related to lymphedema. Everyone's laptop is different.
Yeah.
So as we talked about, as Perla mentioned, we have lots of common skin issues that occur as a result of lymphedema. So we get that dry, cracked skin that you see there at the top left. We get cellulitis skin infections because that skin is swollen and taut, and hairline open areas is just a breeding ground for bacteria and infection to go into. You get that protein crustation. So that's a little, like I said, orangey crust that develops on the skin, and you really need to get that off there so the skin can breathe. It's almost like a blanket that prevents the skin from breathing and then healing. We also get the venous leg ulcers, as we talked about, and then that leakage of fluid through the skin. It's just that constant seepage that we have so much trouble getting in control of in terms of moisture management for wounds. This guy here. Okay, so some of the challenges for patients. So lots of times we have great nurses in the community who can manage wounds. Once you get a referral from your doctor, you go to the wound nurses in the clinics and they do a good job, but sometimes you're doing it alone. You're your own doctor. So there's physical challenges that make it difficult to manage your own wounds. There's lack of education. There's so many wound products out there, you just don't know where to start. There's just too much. When you go to the doctor, sometimes you have healthcare professionals who might not maybe be as progressive as Perla was saying, and so they misdiagnose things and things get missed, and then as a result, you get progressively worse. The lack of access to wound products, that's another challenge. You can go to some pharmacies. I have been to some pharmacies you literally can't find gauze. So, and there's just there. So, it's nice when you can access a pharmacy in the community where you can get wound products. We actually, one of my slides at the end gives a list of pharmacies that you can go to that will provide wound care products if you're managing your wounds. As well as socioeconomical challenges around wound products. They're expensive. Wound products are expensive, especially if they don't work. I know patients that have had wounds for 25 years. So 25 years of $400 a month on just Polysporin. That was one of the patients that I saw. 25 years of $400 a month of Polysporin. And then there was the dressings on top of that. So dry, cracked skin. Unfortunately, all my stuff's over here. I didn't get them out. So when we have wounds, cellulitis like that, you see that protein crustation there, that and as well as venous leg ulcers, the area around the wound, which is called the peri-wound, is just as important to take good care of as the wound bed itself. Because those areas, if they get dry and cracked, there's that hairline open area that's a portal of entries for bacteria. So you really want to cleanse with the pH neutral cleanser, a moisturizer, and then a dimethicone protectant. That's all in one in an ultra wipe. So these are the Tana Ultra Wipes. Thank you. So they're all in one. They're a really nice size. They're dispersible. You just throw them away when you're done, and they do a really nice cleanup, and they donate a beautiful amount of moisture to that peri-wound to prevent any infection, cellulitis, especially with VLUs. Incidentally, this isn't our topic today, but they're really great for skin tears prevention too. So they're just any wound, any peri-wound that you need to donate moisture to, it works amazing. We also have a really nice debridement pad. It's that guy right there. Unfortunately, I didn't get my sample in time, but it's essentially a little scrub pad that you can just donate saline to it, and it comes in its own sterile tray, and you can just give the skin a scrub around if you've got crustation, and it takes care of that beautifully, just debrides that off. So today, like I said, we'll focus on mostly venous leg ulcers. We touched a bit on cellulitis, and blisters are some of the things that we would see as common problems related to lymphedema wound issues. So when we talk wound healing to people who don't do wound care every day, we try to keep it as simple as possible. So there's really 4 main components to wound healing, and that is in the circle there. So you see one component is moisture management, second one's biofilm reduction, thermal regulation, edge of wound. So I'll break that down a little bit for you. So the moisture management is just, sometimes with venous leg ulcers you have excess drainage, and it's just, you can't get ahead of it. You've probably seen those wounds where you would describe them as a dripping tap. And then as a result of too much moisture, you end up, that wound bed gets a film on it that you can't see necessarily. It's called biofilm, and it's just debris and protein and bacteria that acts as an invisible wet blanket and prevents your wound from healing. So if you've had a wound that's about 3 months or longer in duration that you've had, and it looks fine, it's not green, it's not infected, but you can't figure out why it's healing. Sometimes it's related to that invisible wet blanket that needs to come off that wound bed in order for it to heal. The thermal regulation is tied into both the moisture balance and the biofilm. The thermal regulation is the frequency of dressing changes. So when you take a dressing off and you open it to air, that wound cools off. And once that wound's cooled off, it takes about 18 hours after you put another dressing on for it to become the right temperature again to start healing. So if you start peeling that dressing off every day, and then every day, you can never get ahead of the wound healing because the wound isn't the right temperature. So you can see how just based on that, if you don't manage the moisture, you're changing the wound dressing more often. If you don't have that biofilm taken care of, okay, that wound's not healing. If you don't get that moisture managed enough that you can change the dressing fewer than daily, then you're also, having trouble with wound healing. The last part of it is the edge of the wound. The edge of the wound, which is the little area around the very, just on the edge of the peri-wound and the wound bed, if it's a little bit raised, we call it a rolled wound edge, and you'll see a picture in a minute. If that wound edge is a bit raised and rolled, it also will delay the healing. It won't heal because those wound edges need over a wound, the wounds get bigger because the area around the wound gets really soft, and then it's more prone to bacteria, and the wound just spreads. So it also makes you more prone to infection. So what we want to do is we want to pick a product that works to take on a lot of moisture if moisture is the challenge with the wound. So we have a product, can you click, sir, Daniel? Thank you. Oh, sorry, I'm missing a slide there. So I'll just talk about it. So we use a product called Sorbion. It looks like this. So it is a dressing that goes over top of a primary dressing, over top of an antimicrobial if you like. It is impregnated with little beads that turn the drainage from a liquid form to a gel form, so that it allows wounds to have that moisture balance that they need with to promote healing. So I'm going to do a little science experiment. I'm going to put this in my lasagna tin. I'm going to donate, it's the only thing I had at home that was see-through. I'm going to donate 2 liters of fluid to this, okay? There we go. Because as we know, some of those wounds that we describe as dripping taps can easily lose 2 liters of fluid in a day. And so when that happens, you're doing constant dressing changes. I know some patients, they change their dressings 3 times a day just because of the moisture management. So if you give this a minute, you can see it's puffing up a little bit. This is our heaviest absorbent option. And you can see it's 2 liters done. There you go, Pearlie, you want to pass that around? And dry. So
the
it's
moisture's not held.
yeah, so that's not held against the skin. It's actually, if you feel the top of it, it's the perfect amount of moisture to promote good moisture balance for healing. So when you're thinking about those wounds that you're just that vicious circle, it's a great option. Yeah, next slide.
What does it call?
It's called Sorbion. So it does come in different sizes. It comes in from sizes from little guys like this that are stars, which are perfect for elbows or heels or malleoli, to bigger stars, to like 10 by 10 to 20 by 20, 20 by 30. So it's really good for that different varying sizes that you need for wounds. That one that Pearl is passing around is great for a lower leg because you can see there's a little divot in it. So if you're putting it on leg, you can put it at the bottom of the front, the bottom of the back of the leg, the top if you want it around just to circle the patella. So it's great for that. So did we miss the biofilm? Can we go back? Okay, so the biofilm piece of it is actually, we're missing a slide in there, that's weird, sorry about that. So the biofilm is those invisible sugars and proteins and bacteria that we talked about for the wound. There's also a couple other things on the wound bed that would delay healing. One of them is called slough. So slough is that, you see that kind of yellowy, greeny tinge stuff there? People always think it's pus, and then they give it a good scrub and they're like, why isn't it coming off? It's because it's anchored firmly to the wound bed, and it will progress, especially because, it's like a wet blanket that does not allow that wound bed to heal. So we have to debride that off as well. There's also something black you sometimes see on wounds. I don't have a picture today, but if you see any black pieces on wounds, those as well, that's called eschar. That has to be removed from the wound bed as well. So how do we remove all of those chronic issues that's delaying healing? We want to put an antimicrobial on that wound bed that will pull all of that stuff off into the dressing so you give that wound bed a nice clean surface to start healing and breathing properly. So can you, the next one? So again, the thermal regulation of the wound, we talked about that a little bit earlier. If you don't give that dressing at least 18 hours, it's going to be cooled down to, and then that wound won't heal. So we really want to get ahead of the moisture management, the biofilm, getting all that bad stuff off the wound bed, and in order to manage that thermal regulation. So the edge of the wound that we talked about, you see here where you can see the edges are almost a little bit raised, and then right here as well, you can see that right around the edges it's a bit raised. If those little raised edges aren't flattened in order so that they're, we call it flush with the peri-wound and flush with the wound head, if they aren't flattened, it delays healing because those edges cannot come together to heal the wound. So that's the last piece of wound healing that we want to think about if we're doing our wound care plan. So SCD solutions for all of those problems. Go ahead.
Thank you, Rochelle. And Rochelle's too kind in saying I'm the hydroferic blue expert. I just really like wearing blue. And I haven't figured out a way to get rid of me yet, so here I am. So with hydroferic blue, there's a few different types of dressings that can address all these different wound needs. So we have our classic and our ready portfolio. A couple of commonalities with all of our dressings is all of our dressings are impregnated with gentian violet methylene blue, which gives it their wonderful color. We don't add any food coloring to these. And it also gives them their antibacterial properties as well. Something else that they all have in common, they are all non-cytotoxic. So nothing will ever be released from these foams, like a silver and iodine normally would. The main function of all our products is to wick bacteria out of a wound and kill it here within the foam itself. There are two different types of foams within the hydroferic blue family. So we have the classic, which come hard out of the package like this. These are a polyvinyl alcohol foam. When I was taking my tour in Connecticut, where they manufacture these, I tried to sneak in to see the science behind the polyvinyl alcohol technology, and they politely told me where to go because they don't want that secret getting out. I'm in sales, I have a big mouth, so that wouldn't last too long. So they're smart enough for that. So the polyvinyl alcohol foams always come hard out of the package like this. They require pre-moistening with saline or sterile water so they can function properly. So that makes them soft and conformable like this. The last thing we want to do is put something cardboardy and hard on a patient's wound because they might hit you with something. So you want to do something that makes it soft and conformable I'll pass it around just a moment. It also adds a soothing element to it as well. The analogy I always like to use is think of your kitchen sponge in the morning, right? If you spill milk on the counter, the last thing you want to do is throw a rock hard sponge on it because it's not going to do anything. You want to activate the pores, so you run it under the tap. Same idea with hydroferic blue classic. By running it under that tap and pre-moistening it, it activates the pores, so it can function by wicking bacteria a lot quicker into this foam where it is then killed. The hydroferic blue classic actually have a mercury pull of 71.2 mercury pull, so kind of like the low-level negative pressure wound therapy. So we'll have a demonstration shortly to showcase that. Now the ready portfolio, we're not trying to get fancy with the names here at Hydrofera. As their name indicate, they are ready out of the package. No pre-moistening required. These are good to go. These are a polyurethane foam. You cannot pack with these foams like you can with the classic. These are meant for superficial wounds with lower to moderate levels of exudate. However, they are still non-cytotoxic and they still have that antibacterial property within them. So we have a little demo here. I'll show you this now. So the Hydrofera Blue Classic, as mentioned before, I don't know what the best way to do this is, if I want to walk around the room or not, and just talk for a second or two, or Rochelle, if you want to do this, just so everyone can see that. So Rochelle's going to walk around and show you this demo up close and personal. Essentially, we can, no joke, stack these foams all the way to the ceiling. As long as there's exudate, it will always have that vertical pull from the base of the wound up into whatever cover dressing you have. You'll also notice that the Hydrofera Blue Classic, the exudate will not shoot out like a sprinkler system. So when the foams are saturated, that exudate needs somewhere to go. So that cover dressing is very important in the Hydrofera Blue. We have a slide in a little bit indicating the use for the appropriate secondary dressing. So it's not a one-size-fits-all. It is a cover dressing based on the level of exudate exiting the wound. So if you have a ton of exudate, think of something like super absorbing, like that Sorbian you just saw a moment ago. And if the wound is on the drier side, you can use a transparent film to lock in the moisture balance for the full wear time. Spoiler alert, Hydrofera Blue Classic has a 3-day wear time, and there's a little jingle associated with that. If it turns white, it's lost its fight. If it stays blue, change in 72. That is trademarked. You must do that. Just something cheerful to make it easy to remember for people. So this is your clinical indicator for any one of our foams. This includes our polyurethane ready portion as well. If the foam itself turns white, it has run out of its antibacterial properties and it is time for a switch. The classics are a 3-day wear time. The readies are a 7-day wear time. So for the readies, I like to say set it and forget it. Again, being that they're for superficial wounds, this is something ideal for a venous leg ulcer. You can kind of wrap it with our larger size, put it under compression, put it under total contact cast, and you are good for a 7-day wear time with these. Where are we now? Okay, no, actually. So our silicone border here, and I will pass these around. If you would like to do the first stab at it. Our silicone border actually has no silicone over the interface of the foam, so it's in direct contact with the wound bed. Some other silicones on the market have that checkerboard feel over it, so the silicone can kind of impede the intimate contact with the wound bed. With the Hydrofare Blue, that's not the case. You are in direct contact with that wound bed. Again, being a 7-day wear time, Hydrofare Blue ran a study with that silicone border for the first 3 days. They completely removed it 3 times per day and still stuck beautifully. So if you're 5 days into a skin tear, you want to take a peek at wound progression, not a problem, take a peek, okay, it's healing how we want it to, and close it back out, you are totally good to go. I had a cooking accident. I am a fake chef. So I was making fried chicken, of all things, and I had oil splatter on my arm. So I actually threw the silicone border on, just to prove my wife wrong, to be totally honest with you, a little side bet. And I said, I'm going to wear this for a week and shower with it and see how it goes. And she goes, yeah, okay, you're full of crap, whatever, sales guy, typical. And of course I wore it for the 7 days, showered with it, and it stuck on beautifully. Now I would not recommend surfing, but in the shower it's totally fine, and it has moisture vapor transmission as well, so it won't balloon on you. Also, you can write on the back of it, so you can have the date of when you put it on. Totally safe to do so. The transfer, again, not trying to get fancy with the names. It is named so because it has no silicone backing on it whatsoever, double-sided. It does not matter what side you put this on. It will work both ways. And the name is such because it allows the exudate to transfer through it. So you do need a cover dressing with this. Again, ideal for under compression, under total contact cast. Between fingers and toes as well, these do combat a bunch of different bacteria and 3 different types of yeast. I actually had a family friend in a long-term care facility who kept squeezing his fingernails into the palm of his hand. So the nurses just kind of put this on, and he squeezed that, and it got rid of the pain reduction and odor as well. So one of the cool things about Hydrofare Blue is it sort of has this analgesic effect that even we can't explain, but a lot of our patients come back and say it's overnight pain relief for them. So it does increase your quality of life as well. And then the original Ready has the silicone backing on it, and this came out a long time ago. You'd be surprised how many times nurses would put this on upside down and then say, Daniel, why isn't the wound progressing? I ask for a photo and I see the silicone side is on the wrong side. So we printed Hydrofare Blue on it, so there's no confusion now. Wounds don't read, we do. So please have that visual when you put it down. The Classic also comes with a tunneling, so you all had the opportunity to feel this. Actually, I'll pass around both so you have the contrasting feel of the Classic. That is it before it's pre-moistened. So you have that sort of cardboardy, sandpapery sensation. You definitely don't want to put that onto a patient, but you do want to pre-moisten it so that it is soft and conformable. Now I know I mentioned you have to pre-moisten the Classic with saline or sterile water before use. If you do that with the tunnel, we have a tunnel dressing, so if you have undermining of any kind, if you do that with the tunnel, you will get a wet piece of spaghetti, and that is impossible to insert in your tunnel. So please do not pre-moisten the tunnel fully. Instead, what you would want to do is just pre-moisten the tip, insert that into your tunnel or your wound, and the moisture of the wound should help soften it as it's being further inserted. When you reach your depth, wherever that is, cut it to about ½ an inch being exposed, put a smaller piece of Hydrofare Blue Classic on top. What that does is act as a conduit, so for your cover dressing, placed over top, just a larger surface area for it to have more aggressive wicking. If you have a tunnel that's or a larger pressure injury, I always recommend you cut this cinnamon roll technique. Excuse the grade 1 arts and crafts here. And the reason you do this is if you have a really intense pressure injury or any kind of tunneling, it will fit the nooks and crannies that the base that wound really beautifully, and then you can use the flat sheets afterwards to pack on top. The tensile strength on these is phenomenal, so what you put in, you will be getting out. It's not going to rip on you like cheap ribbon or anything like that.
Okay, so I did a little demo with the 2-minute Sorbion. So you can see by the drainage potential for it, it's for moderate to highly exudating wounds. So of course the contraindication for it would not be good for dry wounds or third-degree burns. It's highly absorbent, definitely fewer dressing changes. I encourage you to go home and grab your wound product that you use at home or use at work and donate moisture to it and see what happens when you bring it out. When you bring this guy out, you get absolutely nothing back. It changes it because of the hydration response therapy. It's changed it to it's dry as bone, but a little bit moist on top. You know, so when I took it off the table here, there's just a tiny little bit of moisture, which every wound needs a little bit of moisture to heal, and that's it. It's dry. So that's really important for wound healing. So if you're putting it on by itself without an antimicrobial, it does actually lift some of that debris off the wound. So it's really nice for that. It's good as a secondary dressing, and you can put adhesive over top of it without any issue. It helps to reduce the odor, and it is a sterile dressing and non-latex. So, as we know, Daniel did a great job with Hydrofera. So we're looking at biofilm reduction. Hydrofera is the perfect option because you've got a couple of options depending on how much drainage you have. So if you have a highly draining wound, you would want to use the classic, and then you could use a Sorbion option over top. If you had a moderately draining wound, then you could use something like the Ready or the Ready Transfer or the Ready Border. And depending if you want to use the border one, then you don't need anything to secure it. If you've got the Ready without the border, then you use something to secure it on top. So it's really good for biofilm reduction because it does pull all of that gunk off the wound bed, and you're left with that nice, clean, pink, healthy tissue. So when you look at all of this wound here, you can see some little black piece there. On the process, you can see that greeny slough there. That's not really very good for the wound bed. And you can see the raised wound edges, so you've got all the problems to wound healing in that wound. And if you use the Hydrofera Classic on that, you just need to cut it a little bit wider than the wound edge so that it will pull those wound edges down. The Classic is a really good option for that. And then, like I say, cover dressing.
And our counterparts in the States actually don't have this claim, but Health Canada awarded Hydrofera Blue this claim. We just got biofilm beautifully, as you can see right there, and I can tell you that the reps in the States are not happy that we awarded that. They are not. Also, the Classic is the only dressing on the market right now that will affect all 4 areas of wound bed prep. So time or dime, whichever one you use. So for tissue management, it autolytically debrides beautifully. For infection management, again, it's regulated with that gentamicin blue. For moisture management, the Hydrofera Blue Classic, as you saw in that demonstration, has that natural negative pressure, so you're managing that moisture by pulling it out of the wound bed. And then, of course, edge effect. Cut it about ½ an inch larger than the wound, and it will actually help flatten those wound edges so the wound can revitalize from the base up.
Before you flip that, and just as a cover dressing, this is a really nice option because it does go over the wound bed really nicely. This is a small 8-centimeter one, but it comes in a bigger one, 14-centimeter. It just conforms to the wound a lot easier as opposed to our conservative square dressings, because then you've got kind of pieces sticking out on the 4 corners that are harder to mold to that wound. So this is a really nice option, the Sorbion Star. So, of course, by managing all the moisture management and the biofilm, you're then, managing that thermal regulation. That again is the frequency you're changing that dressing. So if you change that dressing every day, that wound's not going to heal. But if you can use a couple of good options as a primary dressing, or the dressing that goes right on the wound bed, and then a secondary dressing that manages the moisture balance, then you are solving the problem with frequency of changes. So those rolled wound edges, we talked about that already. The Hydrofera Classic is a really good option for that because it does, if you cut it to overlap the wound edges, like it shows in this picture, you can see it's just about a centimeter around, bigger than the wound. It does work to flatten those edges quickly, and then those wounds can close up instead of sitting there like a little island stalling. So I'll do a demonstration, just how to do a dressing change. Unless somebody else wants to demonstrate, and I'll talk through it. Okay. Okay, so if you had a leg, had an ulcer here, I'm going to pick, let's say it's highly draining. Let's say it's, the exudate is copious, we would call it. I would take, especially if it's a lot of drainage, you could use the Classic, or if it's got those raised edges, you could use the Classic for that. We could also use the Transfer, so maybe I'll grab the Transfer. Can you pass me that? I'll do that. So what you want to do is clean the wound bed as you normally would. You want to, if the wound is 4 centimeters by 4 centimeters, you want to make sure that your dressing is cut to fit the wound, especially if you're using the classic. If you're using the transfer, you can actually put the transfer on the wound bed and it can go on the skin around the wound. The classic is the one which is the firm one. The classic is the one you want to cut to fit to the wound, or just a little bit bigger. So we just put that on there. Then you take your secondary dressing, we call it, for high exudate management. You would just put it over top. And then you'd want to fixate it with something. There's lots of options out there. I'm using something called Hypafix, which is water resistant. It's similar to maybe something you would know as a knee fix. So it's water resistant. It's a nice acrylic adhesive, so it's less issues with secondary skin tears when you pull that dressing off. Sometimes you end up pulling or damaging the skin around the wound bed because it's really fragile just by pulling this cover dressing off. So just to be mindful of that. Then you would just secure it like so. And keeping in mind you've cleansed around the wound bed and around the peri wound. And this is actually safe to use under compression as well. So if you're worried, oh, I've got compression and I've got a wound, so I can't wear compression, as Perla was mentioning earlier, if you have a wound and it's a venous leg ulcer, you need compression in order to heal that wound. So we can do the best wound product dressing out there, but if you don't use compression even after the wound is healed, it's not going to heal. So, and as I say, you can use compression over top of this. So you've got the dressing on. Before you walk away from your wound, you want to make sure that the peri wound, the area around the wound, is also nicely cleaned up. So if you have any dry, scaly skin, then you can actually use the ultra wipes and give it a nice bath. And so I do that quite a bit with venous leg ulcers. If I'm doing a dressing change, I'll do a good scrub around the peri wound to make sure that we don't leave any hairline open areas that would be a breeding ground for bacteria, and then the dressing change. So as we touched on, as the wound decreases in drainage level, you also can move to a different middle dressing, or we call it secondary dressing. So you go from a high exudate management secondary dressing to something moderate. So you could use the Sorbion for the high exudate. Once you get down to moderate, you could go to Siltec, which is a foam dressing. Alternatively, which is actually probably an easier path, you could do the Hydrofera border to manage moderate exudate. Once you get down to low exudate, you even have something that's Leukomed or Leukomed sensitive. That's good and easy on the peri wound because it's a silicone border dressing. And then of course the clear transparent film. So access. Access is one of the biggest barriers for people who are managing their own wounds in the community. We have some home health partners in the Fraser Valley area, Coastal Health, Interior Health, yes, go ahead, thank you. That's the list right there. And we have that list available at our booth. If you give us your email address, we can even email it to you. That's just so that you can go to any of these home health dealers in the community and purchase your own wound care products. You want them to be products that you can use easily at home and that are actually nowhere to heal the wound.
And from a Hydrofera perspective as well, it's all 16 of our SKUs are listed on all contracts across the country, which is really great. Getting into, I'm from Ontario initially, but I did oversee national for a few years. Every province has its own unique challenges. BC has some intense challenges that we found out, but it's always fun. So we actually got transfer and border listed about a year ago, which was fantastic. We launched the transfer and border 2 months before COVID. So you can imagine as a brand new rep, being excited to showcase 2 new products and then trying to get myself losing my way into hospitals and say, hey, I have 2 new dressings, and then I have doctors and nurses look at me like I have 3 heads because obviously they didn't make fish to fry. But I can happily say now that we have border and transfer this year, so we're thrilled.
So with that, we also have a user guide that, I should probably, let you see too. We have some of these at our booth, and it's just a really, easy to read picture descriptions on how to apply all of these dressings. So I talked about a couple of them, but each one of them is on this user guide, and so it's really nice to have. Any questions? Those are all our SKUs and order information. That's actually where I was going to talk about Fraser Health, but thanks, Daniel. So when you talk about Fraser Health, it might not mean, you probably, if you don't do healthcare, wondering what does that mean? That means that if you go to a home health nurse in the community and you're using Hydrofera at home, or you want to give it a try, they have it on their formulary, so you can have that discussion with them, and they will know what it is, and they potentially have access to it if they think it's a good option for your wound.
And we also have all the codes for every different region within BC, so interior, Vancouver, coastal, island, Fraser, so we have all that for you as well.
Yeah, so go ahead, Ed.
Right, so, yes, so the Osprey is actually a member of the Classic family, so the polyvinyl alcohol foam. It is a way thinner version of the Hydrofera Blue Classic that you seen earlier. So you don't actually have to pre-moisten this version, but this can be cut to fit size. You can cut the inner ring to fit whatever size requirements you have on the actual unit. The Osprey ring is quite nice because there's two sides to it, a shiny side and a dull side. The shiny side will actually stick to the unit, and the dull side will go right on the patient's skin. If you have pyoderma and it's quite sensitive, you can take your finger, dip it in some saline or sterile water, and kind of just rub the ring so it does soften up just a bit, and you can apply that. It is a 3-day wear time. But if you're just targeting a certain spot of irritated skin or skin breakdown, you can actually cut it into a pizza slice as well, and then you'll be able to target that area as well, and you can keep the rest somewhere sterile. You can come down to the Hydrofera or SNA booth, and we'll get into further detail, and I'll show you some images at the booth. But it's a really cool piece. When I get them at conferences, they go like hotcakes. It's just such a unique dressing.
And it's the same thing, when it turns white, it's lost its white, so you can.
Sorry, the shiny side should be on the wound.
No, the shiny side should be on the unit itself, and then the dull side, much like the Hydrofera Blue Classic that you felt earlier, that hard piece, that will go against the skin actually. You don't have to pre-moisten this version because again, it is super thin, and that area is pretty moist to begin with, so there's no need to add any moisture to it as well.
Okay, so we can, do we have time? Is it 20 after that we're done?
With 20 after is finished, yes.
Okay, so we have time, okay. So we can talk about a case study. So this is a patient that had a, there we go, 79-year-old female patient, chronic lower leg ulcers. Now they progressed to circumferential, so all the way around her lower leg was a big bad ulcer. So some weight bearing issues. She was on something called gabapentin, which helps with neuropathic pain. She had bacteria in her body, which probably a few of us have. It's called methicillin resistant bacteria, and so that bacteria can be troublesome when it gets into a wound because it's difficult to manage that wound if it gets infected, because that bacteria is resistant to so many antibiotics. So you can see Hydrofair already is good under compression, as we talked about, and it's good for those dripping calf wounds where it's just the fluid is coming, patients say it's coming from everywhere. So you can get it on all big, nice big sizes, and it can wrap all the way around the leg, and then you just cover it with the Sorbion. And that's it.
So I have a question, and it's because I'm the BCLA rep here, and so I'm interested to know about all the people in the wound care clinics in the Lower Mainland. What kind of training are they getting in understanding all these new wound management products?
They get a lot of training, so lots of the reps come out, and if there's any new products, they'll introduce new products, and then they do wound management training courses across the board, and they keep up. Their practices are pretty progressive.
Okay.
Yeah.
Because what we know, and many of you know, that many people get their first diagnosis of lymphedema when they show up at the wound care clinic. And they wouldn't be at the wound care clinic if they had got an earlier diagnosis. But thank heavens for those nurses and healthcare people that do finally find them. But it's a shame that it's
Well,
too
they
late.
see it every day.
Yes.
Every day. So
Yeah.
they're the ones that's why I say, like, you might go to your doctor, and your doctor isn't quite sure what's going on. You got a wound, well, just put a dressing on it, or use polysporin. And then you go to the wound clinic, and you get the real story.
Yeah.
Yeah.
And I wanted to ask about those water absorbent. So I don't get it now, but there have been periods in my life, in my arm, when I had the lymphorrhea. And I mean, everything's wet all the time. I use men's handkerchiefs. Do you make the smaller size for arm leakage?
You mean of the Sorbion?
The Absorbion,
Yeah.
yes.
Yeah, there's sizes that are 20 centimeters by 10 centimeters. So on a long, thin arm, that would be a good size. There's 20 by 20s, there's 20 by 30s, there's lots of different sizes. So
Yeah.
yeah, and if you want to come by the booth after, I can give you a catalog.
Right. Thank you.
I'm from Lifecare Medical. I have a medical store that we carry these dressing supplies. I remember before COVID, we had a discussion with your colleagues at SCT, and we got a big portion of all of your products because at the same time from Fraser Health, they asked me to provide this, to have it on hand in case if they refer any patient.
Okay.
But we got some problems. First, they are very expensive. Not anybody can afford it, especially people no coverage. And second of all, since I had it,